Okay. Okay. All right, we are here. Good afternoon, everyone. Thank you so much for joining us on our another community conversations hosted by the Jamaican American Connection. We are here. Of Good afternoon, everyone. Thank you so much for joining us on our another community conversations hosted by the Jamaican American Connection. We are here. We have this special guest here with us, Dr. Camelia Lawrence. Um, Let me just introduce her. Dr. Lawrence is a fellowship trained breast surgeon. She currently serves as the director of breast surgery at the Hospital of Central Connecticut and Midstate Medical Center with Hartford Healthcare. And she's also a member of JAC. And our host extraordinary, Dr. Taneisha Grant, is a board certified gastroenterologist who practices in New Haven, Connecticut. She has been in practice for 13 years and treats adults with a wide range of intestinal conditions, ranging from acid reflux to constipation, and is a strong advocate for colorectal cancer prevention. So again, ladies, thank you for joining us. We look forward to this interesting topic. Um, Ladies and gentlemen online, if you have questions, we will definitely get to them at the end of Dr. Lawrence's presentation. Again, please like and subscribe and share with your family and friends. All right? Dr. Lawrence, Dr. Taneisha, over to you.
Thank you, Craig, for that wonderful introduction. Good evening, everyone. Thank you for taking the time to join us this evening for another community conversation with our very distinguished guest and Jamaican American Connection member, Dr. Lawrence. So, Dr. Lawrence, thank you for being with us, and I'm going to turn it over to you to begin your presentation, please.
Thank you for having me. I'm just going to share my screen here. It's a pleasure and a privilege to be here, and I thank the Jamaican American Connection for facilitating this conversation. Just a bit of housekeeping. Thank you for those who are online. Thank you for joining us. The information provided today is educational in nature and intended for your general knowledge only. It is definitely not a substitute for a medical appointment or treatment for specific medical conditions. So please consult your healthcare provider with any questions or concerns that you might have. So today we're talking about breast cancer. It is the most commonly diagnosed cancer in women in the United States, and it's in fact the second leading cause of breast cancer death. Every year, a significant amount of women succumb to this disease. Last year alone, in 2024, there was estimated about 310,000 women who were diagnosed with breast cancer, and over 42,000 of those women succumbed to their disease. However, there's some good news here. In Connecticut, within our state here, we saw almost 4,000 cases of breast cancer. We had about 420 deaths. Connecticut, interestingly enough, has the second highest number of new cases that are being diagnosed nationwide. We're not exactly sure, but this is a particular statistics that's unique to our state. The good news here is that with the advancement in treatment of breast cancer and with early detection, there are over 3.1 million women who are living today who've had a diagnosis of breast cancer, have been treated, and are now leading healthy and happy lives. The current statistics indicates that about 1 in 8 women will be diagnosed with breast cancer during their lifetime. So imagine you're out for brunch or coffee with 8 of your girlfriends. Approximately 1 of you will be diagnosed with this disease during your lifetime. So we're all susceptible to this disease. Interestingly enough, or alarmingly enough, women of color are twice as likely to die of this disease. We are more likely to be diagnosed with a form of breast cancer known as triple negative disease, which increases a woman's risk for recurrence as well as for distant disease. Breast cancer mortality, you can see here, this is a graph from 2012, actually, from the American Cancer Society. This data still persists to today. The mortality for African American women is about 41% when compared to our American white women. So there's some work here to be done so that we can establish parity in terms of diagnosis and treatment. We want every woman that are diagnosed with this disease to be treated successfully and to go on to lead normal lives. Stage of diagnosis by race here, you can see that African American women are more likely to be diagnosed with distant disease. This is disease that's made its way outside of the breast and into other organs, such as the lung or maybe the liver, sometimes even the brain. Why is stage important? Well, stage does impact prognosis. This graph here shows you that a 5-year survival rate for women who are diagnosed with breast cancer. So local disease is disease that is confined to the breast. So these are stage 0 or stage 1 breast cancer. The disease is started within the breast. It's still confined within the breast. And look at the 5-year survival. It's about 98% with treatment. That's the crux, the cornerstone of early detection. In contrast to women who are diagnosed with later stage disease, those are women who present with distant disease that's now perhaps in the liver, or the brain, or the lung, as I mentioned, or commonly sometimes in the bone. Those who present with distant disease, look at the survival rate, 24%. So there's a precipitous drop from 98% early detection, localized disease, to disease that's now distant and present in other organs. So early detection is key. There are several factors that have been examined when we look at poor outcomes in minority groups. And we talked a little bit about the tumor biology, the triple negative disease. We see about 20 to 25 cases per year in the US, and it's most commonly found in African American women and more commonly in premenopausal women. And as I mentioned before, with triple negative breast cancer, these women are more likely to have recurrence, they're more susceptible and more likely to have distant or metastatic disease. There are also underlying patient morbidities, comorbidities that increases a woman's risk for breast cancer within the minority group, such as obesity, hyperglycemia, which manifests itself as diabetes mellitus. In addition, inadequate receipt of appropriate treatment. The management of the breast cancer is really today an individualized approach. I often share with my patient that there are traditionally 3 arms in the management of breast cancer patients. One is surgery, the other is chemotherapy/endocrine therapy, and the third is radiation. Now, not all women who are diagnosed with breast cancer requires all 3 arms, but if you do require, let's say, surgery plus radiation or surgery plus chemotherapy and radiation, and you only complete part of the treatment, your overall survival is decreased because of the inadequate treatment or inability to complete the treatment. So you do want to make sure that you complete the recommended treatment protocol that has been given to you. There's disparity in screening. African American women are less likely to be screened, which means that they're presenting at a later stage with a larger size tumor. We just talked about the importance of stage. The majority of breast cancers that are diagnosed within the United States, we find them on mammography. Mammography identify breast cancers when they're very small. There are some breast cancers that don't present as necessarily a mass. It may present in mammography as a grouping of microcalcifications that you and I are not going to appreciate on a self-breast exam or a clinical exam. Hence, it's important for you to get your screening mammogram because we'll be able to identify the cancer, hopefully, at its earliest stage when it's most suitable. Socioeconomic factors play a role as well as mistrust of the health system. There are folks who are hesitant to seek medical attention due to a distrust of the health system. breast cancer is primarily a disease of women, but men do get breast cancer. I share with you this image today of Matthew Knowles, who was diagnosed in 2019 with early stage 1 breast cancer. He noticed some bloody nipple discharge, which led him to seek medical attention, had a mammogram, an ultrasound, followed by a biopsy, and then went on to have a left mastectomy. In the US, on average, we see about 3,000 cases annually of male breast cancer, and it's typically associated with a BRCA mutation, the BRCA2 mutation, actually. Now, the majority of the average age, rather, of breast cancer is about 50, between 50 and 60, I would say. If you look here, you'll see about 24% of breast cancers between 50 and 59, and between 60 and 69, they're represent about 30%. But we are increasingly seeing younger women with breast cancer. The blue area here, which represent about 16%, coincides with women between the ages of 40 and 49 who are diagnosed with breast cancer. I can tell you that anecdotally in my practice, I'm starting to even see younger women in their early mid-30s who are being diagnosed with breast cancer. So what is the number one risk factor for breast cancer? Is by virtue of being a woman, female gender, as well as your age. As we age, our risk for breast cancer does increase. You can see by age 40, it's about 1 in 233. By the time you get to age 60, it's about 1 in 22 risk for developing the disease. So what are some of the risk factors for breast cancer? We talked about age as well as gender. The BRCA mutation, BRCA1 or 2 mutation, does increase a woman's risk of breast cancer. The majority of breast cancers that we see in the United States, we actually don't know what caused them, but about 10% can be due to a genetic factor. This is a change in the DNA that increases your risk for breast cancer. Also, if you have a family history is king. It's very important for you to know your family history. You can have a family history of breast cancer without any genetic testing that has yielded a specific mutation. But by virtue of having a family history of breast cancer, your risk is somewhat increased for the disease. Other risk factors include density. Having a high breast density increases your risk. If you've had prior malignancy or any sorts of radiation, such as lymphoma that requires radiation to the chest wall, that increases your risk of breast cancer. Never having children does increase your risk for breast cancer, or having your first child after age 35. There's certain biopsies of the breast, while they may be benign, such as atypia or LCIS, does increase a woman's future risk for breast cancer. So where are we today? We know that only 15% of all BRCA mutation carriers are actually identified. So that means that there are about 85% of folks walking around that has this mutation that we have not yet counseled and tested for this mutation. Why is this important? Well, if you take a look at this graph, the green line represents folks that are carriers of the BRCA mutation. The red is those with a family history of breast cancer, and the blue line is for the average woman's risk of breast cancer. And you can see that there's an exponential increase for those who are carriers of the BRCA mutation to develop breast cancer. The current data alludes to the fact that the lifetime risk of developing breast cancer in the BRCA population approaches about 85%. And this mutation not only increases a woman's risk for breast cancer, but it also increases her risk for ovarian cancer. Some of the hereditary genes that are also have been identified since 1990. We started with the BRCA1 mutation on chromosome 17. Subsequently, the BRCA2 mutation was identified in 1994. But since then, the PALB2 mutation has been identified, the CHEK2 mutation, ATM mutation, and their ongoing research to identify additional mutations that increases a woman's risk for other cancers, not just breast. But we know that the majority of mutations are still undiscovered, so there's still a lot of work to be done within this space. So who should be tested? Well, if you've been diagnosed with breast cancer, you have any of the following: family history, male breast cancer, ovarian cancer, pancreatic cancer, multiple family members of breast cancer, then you should definitely be tested. Ancestry plays a role. We know that women of Ashkenazi Jewish ancestry had an increased risk of being carriers of the BRCA mutation. That should definitely be taken consideration at the time of intake regarding medical history. If you've been diagnosed and you're younger than 50, you should consider genetic testing. Cancer type: women with triple negative breast cancer by age 60. If you've had male breast cancer, if you've had more than one type of breast cancer, you should definitely have genetic counseling and testing. The genetic testing can be done by blood sample. I would say we're moving away from using blood sample, and many of the testing that's now being done can easily be acquired through saliva collection. This is the more frequent approach that is utilized for genetic testing. We know the BRCA mutation in the U.S. is about 1 in 300. If you are a member of the Ashkenazi Jewish community, the risk increases to about 1 in 100. And why is it important to have this information? Because there's risk reduced in things that a woman can do to prevent herself from developing breast cancer. A few years ago, Angelina Jolie shared her story publicly, which I think we now know as Angelina effect. But if you recall, her mother was diagnosed with breast cancer and tested positive for the BRCA mutation. Angelina subsequently was tested herself. She was a carrier of the mutation, and she elected to undergo bilateral risk-reducing mastectomy to decrease her risk of having to deal with breast cancer in the future. What are the current screening guidelines? So who should be screened? I think that every woman by the age of 25 to 30, you should have some idea of what your personal risk is based on your family history. It is recommended that between the ages of 20 and 39, you should at least have a clinical breast exam every 3 years. The current recommendations by the American Society of Radiology, as well as the American Society of Breast Surgeon, is that you should begin your mammography at age 40, and it's once a year along with a clinical exam. I often get questions from patients about self-breast exam, monthly self-breast exams. The current data does not show that a self-breast exam necessarily increases or improve the overall survival for breast cancer. But what I often tell my patients is that a woman who examines her breasts and understands and knows the landscape of her breast is more likely, she's more apt to identify any changes within the breast and to seek medical attention right away. Changes in the breast could be something as simple as nipple inversion, nipple discharge, dimpling, redness of the skin. These are all changes within the breast that warrants medical evaluation to ensure that there isn't an underlying process unfolding. There is sufficient data that shows that screening mammography decreases mortality. The test finds cancer early when it's most treatable. And mammography is standard of care. I have patients who say, can I just get an ultrasound instead of mammogram? And the answer is no. Mammography is the best tool, screening tool that we currently have, and an ultrasound cannot replace it. The ultrasound can be added to mammography as an adjunct, especially in women who have dense breasts. The ultrasound offers another opportunity to look at the breast tissue. For example, let's say a woman who has a mammogram and there's a small breast cancer that presents as microcalcifications, you'll be able to see those little speckles of calcifications in mammography very easily, whereas it's very difficult or sometimes almost impossible to appreciate the same imaging on an ultrasound. If you're at an increased risk, an MRI may be of utility. The current recommendation is that if your lifetime risk is greater than 20% for breast cancer, that MRI should be considered as part of your screening modality for breast cancer. Now, if you're a carrier of the BRCA gene, mammography starts earlier. The recommendation is that you actually begin mammography at age 25, and you're followed annually, not just by mammography alone, but also MRI. In terms of ovarian cancer, there's really no good options available. Transvaginal ultrasound is limited. The CA-125 blood level, this is very nonspecific. So the recommendation for those with the BRCA mutation in terms of risk reduction for ovarian cancer is once you're done with childbearing, you should perhaps consider oophorectomy. So what to expect? You're going for a mammogram. What should you expect? Well, typically, there are two views that are done on each breast. One is considered the craniocaudal view. The other is the MLO, which is the medial lateral oblique view. And these images, now we do what's called 3D. This is a 2D image, but in some places you may be able to get a 3D tomosynthesis mammography, which really just allows the radiologist sort of scroll through the images of the breast. Think of it as a forest. The 3D allows you to look straight on at the imaging, whereas the 2D rather allows you to look straight on at the forest and you get an image and you try to dissect as best possible. Whereas the 3D is almost like you're walking through the forest and you can look at everything around, so it gives you a more in-depth evaluation. A common question that I encounter is regarding the density of your breast. The breast is made up of fatty tissue. It's also made up of fibroconnective tissue and fibrous tissue. Fatty tissue shows up as black on mammography. If you take a look at the image here on your right, you'll see that this breast is considered fatty breast tissue. It doesn't have a lot of density. This is a mammogram in which if you were to develop a cancer, it could be easily identified. In contrast, at the opposite end of the spectrum is the level 4, which is a woman that has extremely dense breasts. Now, cancer shows up on mammography as a white area. So if you're very dense, you can see how easily the cancer can blend in with the dense breast tissue, making it incredibly challenging for the reading radiologist to identify a malignancy. This is just an image that shows you a woman that has a fatty breast who's developed a breast cancer, and you can clearly see the arrows pointing here to that white spot. That's where her cancer is. In contrast to a woman that has a very dense tissue, and look at the arrow. This is where her cancer is, but you can see how the cancer nicely blends in with the dense breast tissue. So I'll just wrap up here by sharing a story with you, and then we can entertain some questions. This is a story of Jennifer. She's a 45-year-old woman who presented to the clinic for routine screening mammogram. She's otherwise healthy, has no medical problems, and she had a mammogram done that demonstrated a new cluster of microcalcifications within the breast associated with a small mass, and thus the radiologist recommended a biopsy. So this is what her mammogram looks like. You see the arrow pointing to this dense area with a few specks of microcalcifications here. So this is the abnormality within the breast. Jennifer complied with the recommendations of the breast team, and she had the biopsy. This is her post-biopsy images. You can see the little white dot here that shows the clip has been placed, and there's still some residual microcalcifications here. Now, why is the clip placed at the time of biopsy? Well, the clip localizes the area of abnormality. So let's say, for example, as in Jennifer's case, this did come back showing a very early breast cancer. It tells the surgeon the exact area that needs to be removed. Alternatively, if this is a benign pathology, for future mammogram, when Jennifer goes in, the radiologist will see this little clip right at the area. So he or she will know that that area has been worked up and has been sampled appropriately. So she had DCIS. DCIS is considered stage 0 breast cancer. So this is very early breast cancer. It was hormone receptor positive. And she went on to meet with our breast center navigator. Within Hartford Healthcare, we have a multidisciplinary team that reviews the breast cancer cases. In Jennifer's case, she only needed a lumpectomy, so just removal of the area with the DCIS. And then she was referred on to her medical oncology colleagues. Please keep in mind that not all breast cancers are the same. There are some cases where surgery is not the first line of treatment, which is why it's important for you to be evaluated within a multidisciplinary team. In some subset of patients, chemotherapy prescribed by the medical oncology team may be the first line of treatment. For example, women with triple negative breast cancer that's greater than 2 centimeters, or if you have node positive disease, there is data that shows that those women are a subgroup that benefit from chemotherapy as first line, followed by surgery. Or if you have HER2 positive disease that's greater than 2 centimeters with node positivity, you benefit from chemotherapy first. I sometimes have questions in terms of patients are concerned about feeling deformed after their surgical intervention. There has been several advances made in terms of surgical technique. This image here shows a woman who had a unilateral mastectomy. You can see there's some deformity of the chest wall here. There has since been evolution. We are now able, in some cases, to perform what's called nipple-sparing mastectomy. This is a patient of mine. She's 42 years old. She's a BRCA carrier, and she underwent bilateral nipple-sparing mastectomy. You can see at the top here, this is her before image, and the after image here doesn't look perfect as she was before going into surgery, but we utilize an inframammary incision that hides the scar. We went in, we're able to scoop out all the breast tissue while preserving the nipple-areola complex. This is with the help, of course, of a plastic surgeon to do the reconstruction. And she has somewhat of an acceptable outcome that she was very content with, knowing that she had the surgery done and she significantly reduced her future risk for breast cancer. So the big take-home message here is get screened. If an abnormality is identified and a biopsy is recommended, please do the biopsy. In some cases, it may just be a short interval. You may be told, please come back in 6 months for a mammogram or ultrasound. It's important that you return for the short interval reassessment to evaluate whether there has been any additional changes that would actually warrant a biopsy. Know your family history. Family history is king. If you have a strong family history of breast cancer, chances are is that your risk is increased and you do need to be monitored a little bit closer than the average woman. And I often say, while fear, it's tempting, it's definitely not a good strategy. And in conclusion, the diagnosis of breast cancer is not a death sentence. As I presented early on, within the United States alone, we have over 3.1 million survivors. And that's because women are being diagnosed early and they're being treated appropriately. There are several advances in both diagnosis and treatment of breast cancer. So I'll end here. Thank you for listening, and I'll open the platform to any questions that you might have.
Thank you so much, Dr. Lawrence. That was an incredibly thorough and somewhat sobering overview about breast cancer. But I think, information is empowering and knowledge is key in order for us to, make ourselves feel empowered and take advantage of the screening modalities that are available. And as you mentioned, being aware of our risk is the most important thing. So knowledge is empowering. So thank you again for such a thorough presentation. So we have multiple questions from the audience. And so I'll begin with the first question. So what mental health support resources are available for breast cancer patients?
It depends on where you are. Most health systems usually have a cancer institute or a structured program. I can speak to Hartford Healthcare. The breast cancer program falls within the Cancer Institute. We are part of a large multidisciplinary team, which includes a social worker. There is a breast navigator. The approach is treatment of the whole patient, not just the disease process. And for those who require those additional support services, or between our navigator and our social worker, they are plugged in accordingly. There's also support available for family members who are helping to care for these individuals.
Okay, great. And I know sometimes, I know at Yale, they offer additional support such as like bra fittings and, things to actually kind of help with the cosmetic.
Yeah. Yeah, that's an important
Uh,
piece, whether it's
if it's a unilateral
yeah.
mastectomy or bilateral mastectomy, I think there are services regarding the cosmetics and bras and things like that, right?
Yeah, there are actually boutiques that specialize in caring for this patient population. Whether it's a lumpectomy that resulted in a smaller size of the breast on one side in contrast to the other, or it's a woman who underwent a unilateral, sometimes a bilateral mastectomy, you can be seen and measured appropriately at one of these boutiques, and most insurance covers at least two, I believe, or three prosthetic bras annually for these patients.
Right. And just to clarify, unilateral means single
One
side,
side, yeah.
bilateral.
Bilateral means you're removing
We tend to get a
both.
little bit, we assume we kind of,
I know it's the
medical,
medical
medical
jargon.
jargon from time to
Yeah.
time.
Mhm.
Excellent answers. Thank you. Our next question is, how often should I perform self breast exams and what changes should I be looking for? You actually mentioned this before, but would you mind repeating the answer?
Yeah, so it's monthly. I usually tell women to do it in the shower when it's wet and soapy water, and you're feeling for any lumps within the breast. Other changes include perhaps abnormal nipple discharge that you've never had before. It could be a dimpling. You're looking in a mirror, you notice a new dimpling of the breast. It could be nipple inversion, nipple retraction. My nipple is now inverted and it wasn't like that before. It could be skin thickening or redness. I often say when in doubt, it's best to make sure, see your clinician, have them take a look at it, and if additional workup is warranted, they can guide you accordingly. But the first step is really having it evaluated.
Absolutely. And also, I just want to emphasize that it shouldn't be monthly in a random fashion. It should be on the
Yes.
same day of each month. So, for
Correct.
example, the beginning of your cycle,
Mhm.
try to be consistent and not just choose one day of each month. It should be the same day each month.
That's correct.
The next question is a very provocative question, which kind of gets to a bigger issue in terms of um, some cultural differences in terms of how we, take advantage of medical care that's available, or whether or not we discuss, our health issues and privacy and things of that sort. But the question that's posed is that women are more likely to take proactive steps to self-examine the breast
Mhm.
or follow a physician's advice.
Mhm.
How do we encourage men, especially Caribbean men, who are
Mhm.
more reluctant to take proactive measures to do the same?
This is a difficult one. It's not just breast. I think it has to do with all cancers. And I
Healthcare in
think it's,
general.
yeah, in general, men are somewhat less likely to seek medical attention. And this is a generalized statement. It doesn't apply to all men. But I think, any abnormality, whether it's male or female, that you notice within the breast, should be evaluated. If you've had a new lump, it should be looked at. In the case of Matthew Knowles, he noticed he had nipple discharge, which he never had before. And luckily, he sought medical attention and was able to have this taken care of at an early stage. In terms of cultural, I think it's just education. I can't tell you how often I'll come across men who didn't know that men can be impacted by breast cancer, because it's primarily talked about in the space as being a disease that impacts women, but we do know that men, while less frequent, they can be diagnosed with breast cancer.
Absolutely. So I actually really applaud those celebrities who use their platform to really publicize their own health diagnoses,
Yes.
because they have the voice and the platform to really impact and influence, other people.
Mhm.
So I really give Matthew Knowles credit for being brave and being vocal about his diagnosis,
Mhm.
as well as Angelina Jolie and other celebrities who have actually used their voices to bring light to this very important issue for men and women.
Yes, absolutely.
Our next question, how can lifestyle modifications like diet and exercise potentially reduce the risk of breast cancer?
Not just breast cancer, but just about every disease process and all cancers. We know that obesity increases our risk for cancer. hypoglycemia, diabetes increases our risk for different cancer. Exercise is important. It reduces, in addition to the cardiac benefits of being physically active, it decreases our risk. Alcohol consumption, I often tell patients all things in moderation. Doesn't mean you can't have a glass of wine or you can't consume alcohol, but all things in moderation. There's sufficient data out there that tells us that these modifiable risks does decrease our risk for malignancies as well as other comorbidities.
Yep. And also the most recent US Surgeon General, Vivek Murthy, actually
Mhm.
really advocated for the carcinogen label to be associated with alcohol. So we know
Yeah.
it is carcinogen, it is cancer causing. So alcohol increases the risk of all types of cancers throughout
Yeah.
the.
Yeah. A friend of mine shared that with me recently. We were all walking and he brought up the study that led to the recommendation that, now in alcohol, you do have to add that carcinogenic label so the public is informed.
Right, right. So the next question, I think you answered it briefly before, but perhaps you could just share whether or not there are any other strategies for or resources available for emotional and psychological support for those who are affected by breast cancer. You mentioned that there are resources within the healthcare system. Are there other resources
Oh,
outside?
there's several, breast cancer, because it's such a common disease. There's so many great resources. I will tell you, I often tell patients, the American Cancer Society is a great resource for services that they offer. The Susan G. Komen Foundation, the Live Strong program. There's so many different programs that are available nationally as well as statewide that offers support for women, mental health support, and otherwise sometimes it's just transportation that is needed. There are those who help with rent or a mortgage. I know Pinkaid right here in Connecticut has been a great advocate in terms of supporting non-medical expenses that allow women to navigate their treatment a little bit easier without having to worry about, loss of job and loss of income and how am I going to feed my family? How am I going to pay my car insurance, or am I going to maintain a roof over my head? So there are several organizations that are available and are willing to help.
Good. Good. The next question, which you also kind of answered during your slide presentation, but what are the latest advancements in early detection and treatment options for breast cancer?
Well, we've moved away from the days of Halsted mastectomy in terms of the muscle, the breast, and women being deformed. The last image I showed is a woman who had a mastectomy, but it was a nipple sparing. That is an advancement to minimize any sort of deformity of the breast that a woman would have to live with on a long-term basis. There's been advancement in the diagnosis. We mentioned the 3D mammography, which allows us to have a more in-depth look at the breast tissue. Our hope is that we're diagnosing cancer when they're smaller and at an earlier stage, when they're more treatable. Pharmacological agents have been uncovered. It's no longer one size fits all. The management of the breast patient takes a more precise approach, is what we call precision medicine. No two cancer exactly the same. We look specifically at your tumor biology, and the drugs and the treatment recommendations are tailored specifically to match your disease process.
That's incredible.
Yeah,
So that leads to improved outcomes.
absolutely. In the past, we had just, it was a tamoxifen, as an anti-estrogen. We now have about 3 aromatase inhibitors that are utilized in postmenopausal women with hormone receptor positive disease to treat their breast cancer. There are novel chemotherapeutic options that are now available in the market. And there's still ongoing research that will hopefully help us to better treat this disease and optimistically one day maybe eradicate this disease altogether.
I remain optimistic. Is 3D mammography standard of care?
It pretty much is. Most centers offer 3D mammography.
Okay. Next question. How do hormonal changes such as menopause affect breast health? And it kind of ties into the question which follows after that one.
Mhm.
Does birth control or hormone replacement therapy also
Mhm.
affect breast health? So if you could please tackle menopause,
Yeah.
control, and
Mhm.
replacement therapy in terms of the impact on breast health, please.
Yeah. So with menopause, it essentially signifies a decrease in estrogen production for a woman. We often hear about the menopausal symptoms such as the hot flashes, hair thinning, the increased weight that my friends and I now joke about as you get to that perimenopausal window. Um, we talked earlier about age alone being a risk factor. As we get older, our risk for breast cancer does increase. There is some data that suggests that potentially hormone replacement therapy can contribute to a woman's increased risk for breast cancer. However, that data is still evolving. I will tell you that if you're a woman diagnosed with breast cancer, in particular subtype that's hormone receptor positive, you probably don't want to be taking um, hormone replacement therapy. What it means is that the hormone, if your cancer is positive, hormone receptor positive, taking any sort of exogenous hormone is going to feed that tumor, which is creates a more favorable environment for that tumor to develop as well and grow. I often tell my patients that quality of life is also important. And it's important for you to have this conversation with your doctor because you have to look specifically at what your risks are in order to decide whether you can take the hormone replacement therapy or not. And in cases where it is prescribed, it's often the lowest dose for the shortest period of time. But it's not a contraindication, hormone replacement therapy in terms of not at all. It's not all or none phenomenon. It's not black and white.
Yeah. So as you mentioned before, always to remember that you should discuss specific questions with your gynecologist or your primary care provider and have, recommendations tailored to you.
Mhm. Yeah, because they have to take into consideration what are your risk factors.
Right.
So, for example, I can't make a generalized statement here tonight saying that all women should avoid hormone replacement
Right.
therapy because it causes breast cancer or otherwise. It's really a risk stratification understanding, risk benefit analysis in order to determine who should and who can and for what amount of time and dosage.
Okay. You kind of alluded to a possible response to the next question earlier in your slide when you mentioned that women who have children over the age of 35 or women who have never had children have a
Mhm.
slightly higher risk of developing breast cancer.
Mhm.
So the next question poses the question of what is the role of estrogen in breast health and how can I manage its levels?
I don't think there's much you can do about your estrogen production. We're born with ovaries. They produce estrogen as we age. Our ovaries shrink. They produce less estrogen. So this isn't something that I think you can really do anything about. If your question is regarding fertility, then that's an issue that your fertility specialist can check your estrogen level. If it's too low, then it's prohibiting your ability to conceive. They have all sorts of magical algorithm that they utilize to help in that space. But that's outside of my wheelhouse, so I won't take that on.
Yeah. All right. You also kind of answered this before, but do you have any additional thoughts about the effect of chemotherapy and radiation therapy? The question is a little general. I'm assuming this obviously corresponds to the risk of breast cancer, which you kind of mentioned before. That
Yeah.
radiation therapy, oh no, sorry. The question is, what are the potential side effects of chemotherapy and radiation therapy?
Yeah. There are side effects with chemotherapy. I mean, the first obvious is a traditional chemotherapy usually causes a loss of hair, is what women always mention to me. I see the women who present with neuropathy. Um, so it's not without side effects. It's about a risk-benefit analysis. When we think about effectively treating the disease, there's data and research that's been done that allows us to know that the alternative of not um, prescribing this chemotherapy is that the risk of progression of the disease as well as recurrence of the disease. That chemotherapy does help with it. There are clinical trials that have been done that provides this data that allows physician to prescribe it. But of course, certainly I can appreciate that there are side effects that comes with chemotherapy. Radiation, less so much. We now do what's called IMRT, which is precision radiation. It's more targeted therapy, less damage, if any at all, to the lung or heart, which was traditionally areas of concern in the past. The most common side effect that my patients describe regarding radiation is sometimes a sense of fatigue or malaise. There's also can be some sort of like a sunburn to the skin itself. But most patients go on to do fairly well through radiation. In terms of side effects of chemotherapy, it varies woman to woman. I have patients who they go through chemotherapy and you would never know that they're dealing with chemotherapeutic agents, and there are those who are very sick from the drug itself. So it varies one patient to another, but I would definitely I can appreciate that the treatment does come with some side effects.
Okay. Two more questions from the audience, and then I have a question as well. So, members of our community may rely on traditional remedies or have strong spiritual beliefs. How can patients and their families effectively integrate non-medicinal or non-allopathic treatments into the therapy? How can we um, how can conventional therapies be complemented by alternative therapies for the management of breast cancer?
I tell patients to be very open with your treatment team. Um, it's I have patients who come in and will say, I'm not going to do the traditional allopathic approach, and they are working with some alternative medication. And I often say is that present the data that supports this alternative treatment. And a lot of times it's an N of one in terms of sample size. They've had one patient that's been treated and has a success story versus the traditional chemotherapy, which is several years of research and clinical trial that has yielded this data. But what I encourage patients to do is to have a conversation with their treatment team regarding what they're considering. And in some cases, it may be a combination in terms it doesn't make sense to tell a patient who's considering alternative medicine that no, you shouldn't do it, because more cases than not, they go ahead and do it anyway. But it'd be good to know exactly that your treatment team know if you are, what you're taking, because sometimes some of these drugs can actually inhibit the effect of the recommended chemotherapeutic options.
Right.
We don't have enough data yet to tell a patient to not utilize traditional therapy and just to use the naturopathic remedies that are out there. I've been doing this now for approaching almost 2 decades, and I can tell you there have been several unfortunate stories of women who've come in diagnosed with breast cancer, elected not to accept any of the traditional treatment, and unfortunately, I see them several years later with advanced stage disease, which could have been addressed early on.
Right. We're getting quite a few questions, which you've kind of answered before, but are there any specific foods that we should avoid in terms of minimizing our breast cancer risk? I'm assuming it's processed foods, and you
Yeah,
mentioned all before, just in
correct.
all
In
conventional.
general, yeah. There's no specific diet for breast cancer mitigation. I think a healthy, balanced diet, avoiding processed foods, hormone-rich foods, maintaining a healthy balanced diet as well as physical activity.
Yeah. We didn't really speak about the breast anatomy in detail, but there's a question here
Mhm.
about the significance of pain under the armpit.
Mm.
Can you talk a little bit, or
Yeah,
I'll let you answer it. But the
yeah,
question is basically, should we be concerned about a breast abnormality if we have symptoms outside of the breast, the typical breast areas,
yeah.
the
Oh,
armpit?
absolutely. Well, not all breast cancers presents within the breast. There are patients who sometimes present with just a abnormality within the axilla, which is also known as the armpit. It may be an enlarged lymph node or some changes that they've noticed within that region. So in that particular case, I would say definitely seek medical attention. However, breast pain in general, you can feel it towards the axillary area. That's where the tail of the breast is. A lot of times it's hormonally related. The good news is that the majority of time, breast pain is not associated with breast cancer. We actually wish it did because pain draws one's attention to the area, but the majority of time it is not associated with breast cancer. But as we stated at the outset, is that for any abnormality, if it's pain, if it's a lump within the armpit, if it's in the breast, if it's at the inframammary fold, if it's around the nipple, your best bet is to have your doctor take a look at it, evaluate it. If any sort of imaging is warranted, they'll hopefully guide you accordingly.
Right. So I just want to commend you for the work that you do. I wish that we could clone you and have your expertise, replicated throughout, the United States and around the world in terms of reducing the impact of breast cancer. I know you mentioned that one of the impediments to care and to diagnosis is that there is some mistrust within some, minority populations. They don't trust the medical system. And I'm sure when, patients who relate to you and see that you look like them, that definitely helps to improve the doctor-patient alliance and improve compliance. And, they follow your recommendations in terms of screening that then
Mhm.
gets passed on to their relatives as well. So thank you for doing your part in terms of minimizing and decreasing the incidence of breast cancer. I was startled when you mentioned at the beginning of your presentation about the rates in Connecticut. That
Yeah.
would be staggering to me. Is there any research that's ongoing in terms of trying to figure out exactly what's driving those high numbers within the state? What is it about Connecticut that makes the numbers here so much higher
Yeah.
than other
I,
states in this country?
Yeah,
Oh,
I'm unaware of any ongoing research. The theory is that we're screening more women within our state as well, so we might be finding more cancer. In addition, we're an industrial state, so we may be reaping some of the effects of the residual environmental changes. And women are also having kids later in life that may be contributing to increased incidence of breast cancer. But I don't exactly know the answer, and I'm not privy to any ongoing research that's been done to really dissect this. So what we've been doing is using that information to empower the folks in our community so that they understand their risk and they can take the necessary steps for risk reduction as well as ensuring that they get their screening studies done.
wonderful. Thank you so much. Do you have any final thoughts to share with the audience before we wrap up this evening's conversation?
No, thank you for joining us, and I commend the Jamaican American Association for Connection, rather, for putting together this wonderful community series. And Taneisha, I am impressed. Uh, Thank you for taking on this role, and I think they will go on to empower and light those in our community regarding different health issues. So thanks for having me.
And you're welcome. Thank you for joining us. And thank you for the audience for participating so well. And thank you to all our community members who have joined behind the scenes and helping to get this produced and broadcast to everyone. We're going to be having our next community conversation on March 9th about a topic that's near and dear to my heart. It's all about colorectal cancer screening. So please mark your calendars and save the date for that next community conversation on March 9th to discuss all things colorectal cancer awareness. Thanks, everyone, and have a good evening.
Thank you.
Bye-bye.